Welcome, everyone. Thank you for joining the webinar tonight. My name is Lauren Steffes. I'm the marketing specialist at OSMS. Tonight, we have Dr. Michael Parman and Dr. Ryan Ziegler here to talk with us about meniscus injuries. Dr. Parman and Dr. Ziegler both have fellowships in sports medicine. During his fellowship, Dr. Parman was able to provide medical care for the Boston Celtics and Harvard University Athletics, where Dr. Ziegler, when he was doing his fellowship, he was able to provide medical care to both the Cincinnati Bengals and FC Cincinnati. Just so you all are aware, we are recording this webinar, and the recording will be made available on our website at osmsgb.com/webinars by the end of the week. So if you want to go back and rewatch anything, or if you have someone that wants to watch it, you will be able to do so. If you have any questions, please leave it in the Q&A box. And at the end of the doctor's presentation, I will be asking your questions to the doctors to answer. Before I turn it over to Dr. Parman and Dr. Ziegler for their presentation, I do have a few facts that I just want to share about OSMS. So I will go through that, and then I'll hand it over to the doctors.
Share the screen. Let's see. Entire screen. Is that coming up?
Yeah, it's loading in right now. Perfect.
Cool.
All right. If you want to go to the first slide for me.
Sure.
So just a little bit about OSMS. We're a doctor-owned orthopedic, sports medicine, rheumatology, and pain management practice. We have 9 locations across northeastern Wisconsin. Our farthest one north is Marinette, and our farthest one south is Fond du Lac. With that, we have 25 orthopedic doctors, 8 rheumatologists, and 3 pain management physicians that spread their services across all of those locations. At our locations, we have a full range of services. We have X-ray, MRI, CT scans for extremities. We also do DEXA scans and EMGs as well. And that is all on site. These services also include, we have infusion treatments for rheumatology patients. So that's when they need to get their IV via infusion, or their medication via infusion. We have 2 surgery centers, one in Neenah and one in Green Bay, and then a walk-in injury clinic also at Neenah and Green Bay. Those hours have extended, which I will share a little bit more about later. And then on site, we also have physical and occupational therapist partners. If you ever find yourself in a situation where you have an injury or pain and you're not sure whether you should make an appointment, you can access Ortho Access by OSMS. It's a 24/7 free chat service where you can get connected with an orthopedic expert, and they will give you guidance or advice. Ooh, let's have you try these at-home remedies, or that sounds like something that you should go in and be seen for. So this is available 24/7, and if you have any questions. And then here's where those extended hours come into place. So both at our Green Bay and Fox Valley Clinic for orthopedic and sports medicine services and our walk-in injury clinic, we are now open until 7 p.m. Monday through Thursday, and then we are still open Friday, 8 a.m. to 5 p.m. So now that you guys know a little bit more about OSMS, I'll turn it on over to Dr. Parman and Dr. Ziegler.
Awesome. Thank you very much, Lauren. And thank you everybody for attending this meniscus webinar. Hopefully you find this information helpful and learn some little tidbits and facts. And obviously, as Lauren said, if there are any questions at the end of the presentation, please put those into the question and answer tab, and we can try to answer as many questions as possible. So to get started, what we'll do is we'll talk a little bit about what the meniscus is. So in our knee, we have 2 menisci, one medial meniscus and one lateral meniscus. And what they are is that they're crescent-shaped rings of cartilage tissue that serve multiple roles within the knee. And they sit between our femur bone or our thigh bone and our tibia or our shin bone. and they sit between those two bones within the joint of our knee. And the consistency is almost like a rubbery type feel to them. So somewhat firm, but also pliable as well.
So some quick anatomy. The meniscus, as Dr. Parman said, is kind of a fibroelastic cartilage, a rubbery substance that kind of serves as a shock absorber. And the way it does that is it has two attachment points, each one at the front and one at the back, and those attach into the bone. And that has important distinctions in the future for tears that may or may not be repairable. And then the periphery of the meniscus, the surrounding meniscus, the C part, is attached to the joint capsule, which is also important in terms of potential healing and that sort of stuff with blood supply. And as you can see there, again, the C-shaped structures, one on the inside, one on the outside, and the ends of each C is where they attach into the bone to serve as what I would say is like analogous to a bowstring, where you have each end attached, which gives you the tension in the meniscus, and that allows it to serve its shock absorbing properties.
So a little bit more, as Ryan mentioned, about blood supply. So the diagram below basically shows what one of those C-shaped cartilage discs or the meniscus looks like in cross section. So on the right part of the screen, you can see the knee joint capsule, which is where the meniscus gets its blood supply from. And as you get farther and farther away from that attachment site to the capsule, the blood supply gets less and less, and that has a significant reason for why some tears in the meniscus don't heal as well as others, because in order to get tissues such as bones or tendons or cartilage to heal together, we need blood supply and all of the different healing factors that are contained within the blood to get those tissues to meld together. So tears that typically happen closer to the blood supply have a much higher healing potential than certain tears that happen away from the blood supply.
Dr. Parman, real quick, are you able to hide that Zoom thing at the bottom of your screen for us?
Yes, there we go.
Thank you.
Sorry about that.
No problem.
So as alluded to earlier, a little bit about the shock absorbing properties in the meniscus. What does it do? Well, that's one thing that it does. It's a shock absorber, and that's probably the main function of the meniscus, is to serve as a cushion between those two bones that Dr. Parman referenced, the thigh bone and the shin bone. And as well, it increases the congruency of the knee, much like the soft tissue disc in the hip where it deepens the socket. We call that the labrum. Same thing in the shoulder. We call that the labrum. The knee doesn't have that, but the knee does have these two meniscus discs. And as you saw in that cross section, they're kind of triangular shaped. And so they actually make the joint slightly more congruent. And so that's one function. The other function that it has, actually serves in knee stabilization, specifically at those attachment points. So the posterior attachments where they attach into bone prevent the knee from moving forward or backward. And then that has ramifications for other issues when you may tear a ligament that does stabilize the knee as well, like the ACL. So it does function as a secondary stabilizer to the knee. And then lastly, it creates that space for the what we call synovial fluid, or the joint lubricating fluid, to move about the knee. The meniscus keeps those two bones separated along with the cartilage, which allows fluid to move freely throughout the knee.
So then we'll talk a little bit about different types of tears. So not all meniscus tears are created equal. So within those C-shaped cartilage discs, what this diagram is trying to show is different areas where you can get a rent in the meniscus. So there's vertical tears, there's radial tears, there are horizontal tears, and oblique tears. And the way that we treat these various types of tears it varies significantly. So oftentimes with vertical tears, we're able to place stitches or sutures across that tear and get compression across the tear site, and those are often amenable to healing. Vertical radial tears are notorious for not having great blood supply in the area that we talked about earlier, towards the center part of the knee. However, those types of tears, if you think of the cushion acting as a shock absorber, those types of tears oftentimes cause a significant issue when we're talking about the shock absorption of the knee. The oblique tears that you see down at the bottom, where you have a flap in that white zone where we don't get a lot of healing potential, where there's not a lot of great blood supply, oftentimes those are better treated with a meniscectomy, or just removing a small portion so that we no longer have that flap of meniscus tissue that can cause the symptoms that we'll talk about in just a little bit.
And this is just an example of an additional type of tear called a root tear. And this one is of particular importance for us, because this is the one tear that, if you have it in adult stage, can possibly be repaired. I say possibly because while they can be repaired, the candidacy for this procedure still rests on other factors, such as how much degeneration is in the knee. Is there loss of cartilage? Is there alignment issues? So there's other factors that go into being able to repair this type of a tear. But you can see the root avulsion is where the actual bony attachment point of the meniscus is injured. And that is important because that renders the meniscus really non-functional. Because you lose that tension. It's not much different than clipping the end of a bowstring on a bow and arrow. If you clip one end of the string, you will not be able to fire the arrow. It doesn't have the tension. And that's exactly the same thing in the meniscus. If you lose the root attachment, you lose the tension in the meniscus, and it no longer serves its shock absorbing capacity.
So some of the common symptoms that we typically see with meniscus injuries is pain localized to the area of the tear. So for example, if you tear your medial meniscus, we typically would see pain on the inside portion of your knee rather than per se underneath your kneecap. Now, sometimes with meniscus tears, you can also get some swelling and stiffness within the knee, which can also cause pain globally throughout the entire knee joint itself. Some mechanical symptoms that we often see are clicking. So when you bend and straighten your knee, feeling a click or pop between the two bones in your knee, or sometimes even frank locking. If there's a piece of torn meniscus that is flipped between the two bones, that truly prevents a mechanical block where you can either not fully straighten your knee or not fully bend your knee. And then also, because the meniscus does act as a secondary stabilizer to your knee, oftentimes patients with meniscus tears will report some sense of instability to their knee, whether even if they don't have a tear of the stabilizing ligaments, they'll oftentimes say that their knee feels as though, doc, my knee, it feels like it's giving out, or it wants to give way with certain movements. So those are some of the common symptoms that we will see when a patient has a tear in their meniscus.
So I think the biggest question we'll get in the office is, do I need an MRI, or when am I getting my MRI? And the truth is, it depends. And yes, you do need an MRI to quantify the degree of the meniscus tear. So usually a clinical visit will start with an X-ray. An X-ray tells us a lot of information, as you'll see on the next slide, between who and may or may not be a candidate for an MRI. And then this is all very specific to each patient, but if you have no locking, no catching, you have minimal effusion, you have full range of motion, and you just have pain, and maybe you're aged beyond that of your teenage years or early 20s, we typically will trial somewhere between 4 to 6 weeks of conservative management we'll go through later. However, if you present with locking, catching, decreased range of motion, or your knee blows up, I call it like a softball knee or a grapefruit knee, and you have a large effusion, that may be an indication that we need to get an MRI sooner. And then again, the other criterion is that you don't have advanced arthritis on your x-ray, as you'll see on the next slide.
Yeah, so this slide is basically showing what a knee X-ray looks like. And so, as Ryan alluded to, when you have advanced arthritis in your knee, which is what you see on the left side with significant narrowing between the two bones on X-ray, then typically if there's a tear of the meniscus between the two bones, then that's usually part of the arthritic process. And oftentimes going in with the scope and trying to clean out the meniscus or clean out the arthritis is not going to provide any sort of long lasting or long-term relief. So when the arthritis gets advanced to the point where we start to see significant narrowing of the joint space, our treatment options at that point are sort of limited between trialing non-operative treatments such as anti-inflammatory pain medication, physical therapy, stretching exercises, different types of injections. But from a surgical standpoint, when we see that amount of narrowing on an X-ray, really the only option moving forward at that point it oftentimes is replacement type procedures or arthroplasty. Whereas on the right side, if you have a well-maintained joint space with a meniscus tear and significant pain mechanical symptoms, then we know if there's not a lot of arthritic changes within the knee, then oftentimes patients can get benefit from arthroscopic intervention should they ultimately require surgery.
So that goes into a nice segue into our next segment here, into non-surgical treatment options. And so, as you saw earlier, degenerative tears with arthritis. So these are non-repairable tears. In the x-ray that you saw on the left side in the screen before would be an example of somebody with fairly advanced arthritis and what we call kind of classify bone on bone, bone spurs. Those are all terms that we use to describe fairly advanced arthritis. So for those individuals, you're really not going to benefit from a cleanup procedure, as we call it. And so for those individuals, the only surgical intervention may be some type of arthroplasty. So for the meniscus or for the arthritis, we'll do rest, ice, anti-inflammatories, Tylenol. This can also be done in somebody with a normal looking knee, but they lack the symptoms that we were describing earlier, such as locking, catching, maybe there's no large knee effusion. So they can also trial these conservative management. It's not just limited to individuals with arthritis. Therapy can engage the muscles. It can keep the muscles active so that they act and stabilize the knee. Plus or minus cortisone injections can be great because an acute tear may present with some inflammation, and that can get it calmed down. And that may be in the setting of maybe there's some mild swelling, no mechanical symptoms. That's a great time to potentially get a cortisone injection. But again, these treatments are highly individualized.
So when do we do surgery for meniscus tears? As Ryan stated earlier, if you have frank locking or catching of your knee, so every time that you try to bend and straighten your knee, you're unable to because there's a piece of meniscus tissue that's getting ground up between the two bones, or if you have a well-preserved knee, meaning you don't have a lot of arthritic changes in your knee, then that's when we typically resort to surgery for meniscus tears. And so, you know, the treatment options, and we'll talk about this in a little bit, when we try to either repair or remove portions of meniscus, that depends a lot of times on many factors, including age, level of arthritis, the type of tear that we had talked about earlier. But oftentimes, if you can't fully straighten or bend your knee because there's a flap of meniscus in the way, even if you do have arthritis in your knee, oftentimes those patients will benefit significantly from getting that piece of torn meniscus back into the right spot, or simply removed so that it no longer causes those significant symptoms.
And so from a surgical repair standpoint, we're always attempting, from a repair perspective, we're attempting to restore the normal kinematic anatomy of the meniscus. So you can see on the left side there, that's kind of a large displace, what we call the vertical tear or a bucket handle tear that gets flipped over and can be caught between the bones. Those ones that can be repaired are closer on the outside near the capsule, and so we put stitches in it, as you see there. When I talked about the root repair, that one you have to attach back into bone, and so you'll see on the right side there that restores its attachment point. But again, cannot talk about it enough that these are highly individualized, and each person is different and each situation is different. It depends on if you're a 17-year-old football player versus a 70-year-old pickleball player with moderate arthritis. So everything does change according to the individual. So it is a very highly individualized process in the clinic setting.
Another type of surgical treatment option, which we had mentioned before, is a cleanup procedure or a partial meniscectomy, where basically what we attempt to do is any tear that has a loose or unstable flap or edge, we basically smooth out that edge. So we remove a portion of meniscus, so you no longer have a tear that's sort of flapping between the two bones in your knee when you bend and straighten your knee, which oftentimes will help with the symptoms of pain along your joint line, clicking, popping, locking. And then we try to leave as much healthy meniscus as possible, again, to try to have that meniscus act as much of a stabilizer and as much of a cushion between the two bones in your knee when you're walking. And these types of surgeries are very good at reducing pain and symptoms in knees that are well indicated for surgery. Again, if you have a lot of arthritic change in your knee, or the cartilage in your knee is starting to degenerate over time, then the reliability or the predictability following even this type of procedure where we clean things out gets less and less over time.
So recovery, whether it's repair or meniscectomy, that determines a lot. And so repairs are much more intensive with their rehab process. So it's typically 4 to 6 weeks off of the leg, non-weight bearing or some sort of protected weight bearing therapy for 3 to 4 months, and then typically 5-6 months before someone's getting back to the activities. And that's just, these things have poor blood supply. Even the parts that have good blood supply are not that great. It's not like bone where there's abundant blood supply and there's great healing potential. Meniscus in general heals slowly. So that's why you see the long recovery period there. A meniscectomy, on the other hand, or again, your quintessential cleanup procedure, much more straightforward recovery. Weight bearing is tolerated because we're not waiting for something to heal. As Dr. Parman showed you on that previous slide, we kind of trim out the torn part of the meniscus, leave as much good tissue as possible remaining. So there's no need to brace, plus or minus physical therapy just to get someone moving again. I typically do. And then around 4 to 6 weeks, depending on the patient's recovery, they can start to return to activities as they can tolerate.
And I know we've already talked about this quite a bit, but some additional considerations here. So just because you have a tear in your meniscus doesn't always necessarily mean that is the only reason that you may or may not have pain within the knee. And I would say the biggest thing that Ryan and I see often is that patients that have meniscus tears, especially as you get into your 40s, 50s, and 60s, most of the time, the rest of the cartilage or the cushioning, the lining that ends the edges of the bone is oftentimes starting to wear out or degenerate. And so that rest is a full spectrum. And so some of these symptoms of arthritis in the knee also includes pain along the joint line. You can have clicking, you can have popping in your knee because of the uneven surfaces. So a lot of the same symptoms that we see with arthritis are the same symptoms that we see with a meniscus tear. And so the tricky part is determining, okay, what is causing the majority of these symptoms? Is it the early arthritis in my knee, or is it the meniscus tear? Is it a combination of both? And so really it's our job as physicians to speak with the patients and determine, okay, what is the best plan that we have moving forward? What is the level of arthritis? What type of tear do we have to come up with a really individualized approach in terms of how we're gonna tackle this?
So as you've heard us say fairly repetitively throughout this talk, not every meniscus tear is the same, and even the same tear can be treated much differently across the spectrum of ages and even patients within the same age. So it is a very individualized approach, and we always treat the person as and their personal goals, not just an MRI or an X-ray, and so that's very important. And as Dr. Parman had mentioned, preoperative counseling in these situations is a thorough discussion of what to expect after the surgery, because as these treatments were outlining, oftentimes the knee isn't going to be perfect. You're going to have less cushion when you leave. In the case of the cleanup procedure, you're still going to have arthritis of the knee. This is not an overgrowth, which is a common misconception. It's a wearing away of the knee. And so we don't replace the meniscus in that setting. We don't add cartilage. And so for patients in my office, I often tell them, we hope to have you improve, but perfection, to have a 20-year-old knee for an individual that may be in their 50s or 60s is not the attainable goal here. The goal is that you're improved, but not perfect. But improvement oftentimes is a better position than they're in the setting in the office, if we decide to proceed.
Awesome. So at this point, I think what we'll do is we'll have Lauren sort of guide us through some questions, and then hopefully Ryan and I can answer them for us. Let me just stop sharing this.
Absolutely, yes. So it looks like we already have some questions coming through. So if anyone is interested or has any questions, feel free to please put that in the Q&A chat. That just helps me sort through them a lot better. Also keep in mind, I will try to go through and address as many questions as possible. But if there are some questions that we don't get to, please feel free to give our office a call and schedule an appointment, and the doctors can individually answer your questions in the clinic setting as well. All right, let's get started. The first question that I have is, I had a scope last December for a meniscus tear in my knee. I sustained an injury after playing pickleball. I still have some residual pain that never seems to completely diminish when swimming, biking, walking, golfing. What are your thoughts on returning to a higher risk sport, such as pickleball, after a meniscus injury? All of my friends continue to play after they had injuries, but I have not returned to the court for fear that I might make it worse. Would love to hear your thoughts on this. Dr. Parman, do you want to start off for us?
Sure. So I think in this case, again, it's a little bit difficult to come up with definitive conclusions without being able to see like the preoperative MRI or what the meniscus or cartilage looked like at the time of surgery. Oftentimes the expectation, when I have discussions with patients about what the goals are after surgery, things like playing pickleball or return to a prior or similar level of function as compared to prior to the injury, is always the goal for me. It's a little bit hard to say, what the exact cause of the persistent pain is. Is there, was there some early arthritic change within the knee that could be causing some pain or discomfort within the knee, in addition to the meniscus tear as well? As Ryan alluded to earlier, oftentimes following these clean out procedures, it's pretty rare that the knee gets back to 100%, perfect, especially if there are early arthritic changes throughout the knee. From a structural or stability standpoint, I typically will tell patients that if they're 3 months out from the surgery and there was no significant ligament damage within the knee, then oftentimes at that point, I let them return to activities as tolerated, meaning if they feel as though, they can manage their symptoms with anti-inflammatories and stretching and icing afterwards, then from a structural standpoint, I don't think any more damage is going to be done by attempting to return to those types of activities. Certainly if those return to sport is causing significant pain, then it's probably time for a repeat evaluation to see if there's anything else that needs to be done to address that.
Sounds good. Thank you for that insight. Dr. Ziegler, if you want to answer this question, what supplements, vitamins, minerals, electrolytes would you recommend to support healthy joints after meniscus surgery? If you have any.
Yeah, that's a good question. We're not dietitians, and those things are supplements have very low regulation. So I don't want to get too far into the weeds of recommending things that aren't borne out in the literature or well supported. So I don't want to put my foot in my mouth. But I think the best recommendation I could tell you is I would have to say maintaining a healthy diet and activity is probably the best way to go for maintaining your joint health. We know that sedentary lifestyle, poor diet, carrying too much weight on the body, those things all lead to early degenerative changes. And so staying active and stimulating the cartilage through weight-bearing activities will keep the cartilage healthy. And that's going to be way more important than any supplement you can take. Things like chondroitin sulfate or other supplements of that nature. I don't think there's a lot of data to support taking that to prevent arthritis or to restore cartilage. It's just I think it's something you could do that's safe, but I don't think it's going to change the nature of the knee.
Yeah, I would add that after surgery, if you can try to follow some sort of low inflammation diet. So after surgery, your knee's going to be all swollen and there's going to be a lot of inflammation. So avoiding things like refined processed foods that are high, have a lot of inflammation. Also, having some sort of protein source. So we know that like wound healing and things like that can help if you're making sure that you get enough protein in your diet as well. But I would agree with Ryan. There's not a lot of good data to support different types of supplements like glucosamine, chondroitin, things like that. In fact, the American Academy of Orthopedic Surgery, they put out recommendations of what we should recommend to patients, and they basically say that there's really no good evidence to support the use of those types of supplements. Now, again, are they safe? Yeah, but there's really no good data, and if there's no good data, it's hard for us to say, yeah, you should go out and purchase all of these things because XYZ is going to provide a lot of benefit. It's just there's no good evidence to support that right now.
Okay, great. What is the function of the fat pad in the knee, and what happens when it is removed? So I'm not sure what they mean by the fat pad.
Sure. So the fat pad is basically every knee has a fat pad, and it's basically some fat that lies right behind your patella tendon, and it's between the kneecap and your femur. And the role of the fat pad is to provide a cushion between your kneecap and your femur when you bend and straighten your knee. Now, oftentimes with surgical procedures, when we go in arthroscopically through two small little portal incisions, sometimes some of that fat pad has to be resected or removed in order for us to visualize the rest of the knee joint. Sometimes that fat pad also is inflamed and impinged, and so we'll remove that to help reduce some pain. Like you can have pain if that fat pad gets inflamed. And so it does act as a cushion between the two bones, but oftentimes it gets resected. And so from the long-term ramifications of removing that fat pad is not anything significant. Like it doesn't act as a stabilizer between your kneecap and your femur, but it can help act as a cushion between the kneecap and the femur bone when you bend and straighten your knee. Hopefully that helps answer the question.
Great. Yeah, thank you. How often do the tears not show up on an MRI? Is it fairly rare that you are surprised to find a tear? Dr. Ziegler, if you want to address that one.
So it depends on the patient. The MRIs are fairly sensitive to pick up tears, but they're not perfect. And so for individuals who may have a normal MRI and persistent discomfort, with symptoms as previously described, there can be a role for arthroscopy, and occasionally you will find a tear. However, more often than not, the MRI will pick up a meniscal tear. The other thing to take into account too is sometimes there's injuries that are fairly complex, and there's a lot of edema in the knee, meaning bruising, swelling. There's tears of ligaments. And so the MRIs become slightly less specific in that setting, to even maybe it may pick up a tear, but we can't tell if it's repairable or not repairable until we get in there. So again, to answer the question, the MRIs are fairly sensitive to pick up meniscus tears, but they're not perfect. And in the clinic setting, it depends on the patient, what their symptoms are, as to what next steps might be.
Mm-hmm. Great. This question is, I tore my lateral meniscus in the front and had a meniscectomy in February of 2025. 7 months later, I retore my lateral meniscus in the back, and now I'm 3 months into recovery. Is it common to see repeat tears like this, or does one tear increase the possibility of an additional?
I would say, I always tell my patients that if we take out a portion of your meniscus, it's always possible you could twist your knee, you could have another injury. So it is certainly possible to tear your meniscus in a different portion. As we had alluded to earlier, the meniscus it does have a stabilizing function in your knee. So depending on how much meniscus was removed at the first surgery, that could have caused some micro instability in the knee that could lead to the possibility of having another tear in the meniscus if the knee isn't as stable as it used to be. And so a new twist could cause a new tear, even in that same meniscus in a different place. So it certainly is possible. As far as how common it is, I don't know that I could put like a certain percentage on that per se, but it's not something that, we certainly have seen before.
Good to know. What exercises are used to keep the knee healthy, especially after meniscus surgery? And I just want to point out too, if there's any PT protocols that we have on our website that you want to call out to, I think that would be great as well.
Yeah, we have a number of protocols, from non-operative knee exercises to post-operative protocols for meniscal repairs and meniscectomies. Those ones are a little bit more difficult to follow because they're PT protocols rather than straight exercises. So you can find the knee exercises on our website, though. And typically they revolve around quadriceps, hamstrings, strengthening the muscles around the knee so that the knee becomes more stable. I also have my patients do core and hip strengthening. I think there's a big connection between the core, hip, and everything's connected, certainly. But I also throw those in for patients looking to strengthen their knee. I think starting with the core and hip and then strengthening the muscles around the knee is a good way. And again, can't go through every specific exercise, but those exercises are on our website and in our clinic setting, and we can get those to any individual looking for them.
Mm-hmm. And I did just put the link to that website page in the chat if anyone is interested in going and visit that on our website. All right, next question is, I've been a daily runner for 50 years. I had my surgery in December. I've been running for a week and a half now. Everything is going well. Can I go 6 miles, or should they stay at about 5 miles an hour?
So if the surgery was 3 months ago, I always tell my patients that this is a very, I would say, individualized question. And so when you're getting back into activities, the best way to go about that is to start low and slow and sort of work your way back up to your normal routine. So if, for example, right now you're running 4 or 5 miles per day and that seems to be going well and you're not having any pain or discomfort in your knee, then maybe the next time you go out for a run, maybe you increase your distance by a half mile, or you increase your pace by 30 seconds per mile or something along those lines. And you just sort of slowly test the waters rather than going from let's say you're 2 or 3 months out from a surgery and you haven't run yet, and then you just decide to go out for a 3 mile jog. That's what we want to avoid, because we don't want to shock the knee. We want to slowly work our way back into our normal routine and get back to the same level that we were at prior to the injury or prior to the surgery. So there's no specific, I always tell my patients, everybody's knee journey and recovery is different, right? Some is a little bit faster, some it's a little bit slower. You'll have good days, you'll have bad days, but as long as you're moving in a positive trajectory or a positive direction, that's what we want to see. And there's no specific mileage cutoffs per se, but if you're doing well at 4 or 5 miles and things are going well, I would say that that's pretty darn good following a knee surgery 3 months out. And it's probably okay, if you're feeling good, to start slowly increasing your mileage at that point. And I don't think that it's going to do anything wrong from a structural standpoint.
With a cleanup, would you also remove any bone spurs?
Yeah, so with any arthroscopy procedure, or the quintessential scope and cleanup, bone spurs, one, is an indicator of arthritis. And so people often think that arthritis is an overgrowth, and it's the opposite of that. It's the loss of cartilage, and our bodies don't do a great job of restoring the cartilage. This is why we do scopes and knee replacements. And so, but the body does make bone. And so to fill that lost void, it often makes bone, and it shows up on x-ray as bone spurs. And so depending on the degree, one, you may not be a candidate for surgery. If you have too many large bone spurs, it may be an indicator that your arthritis is more advanced. But the bone spur itself is not the cause of any meniscus tear or arthritis. It's the downstream effect of losing the meniscus that causes the loss of cartilage and the creation of these bone spurs. So it's a third level problem. So removing the bone spur is not part of the process of those arthroscopy procedures, because it's not part of the problem. So we don't typically remove those.
However, I will say that in addition, when we're talking about the cleanup procedure, if you do have a meniscus tear that we are doing a partial meniscectomy on, if there are loose flaps of cartilage that are sort of flapping off of the bone, we will smooth that out at the same time, so that hopefully, that cartilage, if it's already pulled off of the bone, it's certainly not going to heal back down. And it's really only causing harm and not any good. So we will remove any loose flaps of cartilage that are lining the ends of the bone in effort to smooth that out, to help with the mechanical symptoms like the clicking and locking that may be caused by those, by that loose cartilage.
Is it harmful to wait too long for a cleanup procedure? Someone was diagnosed last September with a torn meniscus.
I would say for the answer is for a clean out procedure, like if you have early mild to moderate arthritis and a degenerative meniscus tear that is, deemed not fixable or not repairable based on its MRI qualities, then there's not necessarily a time sensitivity to that surgery. And that's why we say trialing things like a period of rest, anti-inflammatory medications, plus or minus an injection. Those sorts of things aren't going to burn any bridges, because you can always go in and trim out, the loose, unstable pieces of meniscus at any point. It's really when we get to the types of tears, like the root tears that Ryan was talking to earlier, or if there's a bucket handle tear where you can't bend your knee, or a tear that is more repairable, or if you don't have any arthritis, that's when we do typically want to try to get to those sooner rather than later with surgery. If we're gonna attempt a repair, it's better to do that sooner rather than later, to try to fix that meniscus while it still has a little bit of healing potential. But when it comes to the clean out type procedures, you're not really going to burn any bridges by waiting a little bit longer and trialing non-operative treatment.
All right, this person is active in mid-50s, male, and 8 weeks post-op. They had a 30% of medial meniscus removed. They have very little arthritis in the knee with very little pain, and they would like to return to running activities. If they do, am I going to accelerate eventual arthritic changes in the knee, or is there a way that they can do it safely?
Yeah. So when you return to running anytime after a meniscus procedure such as this, whether you had the surgery or didn't have the surgery, that part of the meniscus really wasn't functional to begin with. So 30% loss, while significant, it still left you with a fairly good portion of the meniscus. And obviously we can't see the images or the arthroscopy pictures, but if I just can take it at face value, 30% leaves you with a good amount of meniscus. But it does remove some. Some was taken away. And so for that reason, you will have lost some cushion. And yes, returning to running does stress the body. And it can lead to some changes in the cartilage. But I would argue the counterpart that, again, leading a sedentary lifestyle or avoiding those types of activities, trying to preserve the knee can actually do more harm. So certainly there's limits. I mean, if you go out and run 100 milers or you're running 50, 60 miles a week, that may be different than, hey, I'm running and cruising 12 miles, good shoe wear. I think there's little concern there. And I would, if I'm just, again, taking this at face value for this patient, it sounds like something he could safely return to running without the fear of causing or worrying about more arthritis developing.
Yeah, I would agree. I would say the benefits probably outweigh the risks in that sense.
Great, yeah. What about a compression knee stocking? Is it worthwhile or not?
I always tell patients this is kind of like the different supplements, things like that. So when it comes to a compressive knee sleeve, if you have a meniscus tear without any ligamentous injury, and the meniscus can give you a sense of instability. So sometimes a knee sleeve will give you an added sense of, protection around the knee. It's maybe not providing a bunch of like extra help from a side to side support standpoint, but it may help with some of those symptoms of that, your brain sort of perceiving that your knee is a little bit unstable because of the meniscus tear. And so I always tell my patients that, again, it's not going to cause any harm, and it may make your knee feel better when you're trying to return to these activities if you're trying to treat this without surgery. So I always say, it's worth going for. I wouldn't spend $200 or $300 on a knee sleeve, but going out and buying something over the counter, find something that fits, that makes your knee feel a little bit better. It can only help.
Great. Is it okay to stay active with a tear, like using a treadmill or stationary bike?
Yeah, I think similar to the previous answer, the benefits definitely outweigh the risks. We know that weight-bearing activities stimulate the cartilage to stay healthy, and so I tell all my patients that I'd do anything to keep them active. I think they should be active. They should be trying to do the things they want to do. Again, there's limitations to that. If someone's trying to rock climb or deadlift certain PRs, yes, those things will potentially cause risk and harm. But if we're talking about running on a treadmill, going on a bike within reasonable distances and times, I say absolutely go for it. The benefits outweigh the risk.
You mentioned that oblique tears often require surgery to remove the flap. Can you talk a bit about an oblique tear, and can it be managed conservatively?
Yeah, so an oblique tear is one where it typically happens in a zone of the meniscus that doesn't have great healing potential, and there's usually often a flap that will sort of flip back and forth between your thigh bone and your shin bone when you're walking or running or jogging or trying to do any sort of side to side or twisting movements. And so oftentimes the symptoms are pretty significant. So symptoms like clicking, sometimes locking, certainly pain along the side of the knee with side to side or twisting movements. And again, when we talk about a meniscectomy or a debridement, there's no time sensitivity or urgency to it. But that being said, if you have an oblique tear and you're experiencing the symptoms that I mentioned before, those are ones that typically do best after surgery to just remove that little flap of cartilage that's flipping in and out, especially if you don't have a lot of arthritis in your knee. Like those are ones where if I'm going in with a scope and I trim out that little flap, and it's like clearly that is causing the patient trouble, and you make things nice and smooth, those are the patients that do the best after meniscectomy or clean out procedures. So yeah, there's no urgency to going in with surgery, and you can try to manage it without surgery, but that meniscus tear will not heal on its own. And so I tell patients, it's kind of like having a pebble in your shoe, right? If you have a pebble in your shoe and it's on your heel, it's going to cause a lot of significant pain. That pebble may move to your instep and, it may not feel that bad for a brief period of time, but it's still there, right? That tear is still there. And so if you're unable to get back to the activities that you want to do because you're having persistent symptoms, like clicking, catching, sharp stabbing pains, then again, those oblique tears are ones that I think do best with surgery to go in and just trim out that small little flap.
That's a great way to put that. This person had a root repair that was unsuccessful. They were told that they should look into a partial repair. They're currently not experiencing any pain, but weakness and a bit of instability. Do you think strengthening their calf, hamstring, and quad are sufficient enough to get them by a few years, or is it worth them to get the partial replacement?
Yeah, so again, difficult to determine just without seeing the information, knowing more about the patient. Yeah. And so obviously we encourage anybody that's on this webinar, make an appointment. If you have any interest, we're happy to see you. I think that illustrates some key points that we talked about in the presentation, that root tear does render the meniscus non-functional. And so for that individual, the partial knee replacement may be the next surgical option. It sounds like it is, which would be appropriate in the right setting, because once you repair these and they fail, to get a successful repair a second time is not going to have a high percentage of success. You could certainly potentially try it, but unlikely to be successful. So I would say this person has minimal downside here to continuing their efforts to conservative management, because I think I heard you correctly say there's minimal pain. They're doing okay. I would absolutely advocate for quad, hamstring, strengthening and stretching of the Achilles and gastroc. As I said before, core and hip strengthening, I'd throw in there as well. So from my end, this person would continue to do well with that. And sometimes for these individuals, we'll watch them on a yearly basis just to ensure that there's no further development, or in the setting of some arthritis, we'll have patients come back yearly to monitor when they're not candidates for scopes, just to ensure there's no significant advanced changes. But from what I heard from you, I would tell this person to do those things.
Good to know. Just looking at time, it looks like we have a few minutes left, and we still got quite a few questions, so we'll get through as many as we can. But like Dr. Ziegler said, if any of your questions aren't addressed, or if you have pain and would like to be seen and evaluated, please feel free to give our office a call, or you can schedule an appointment online as well. All right, let's continue on. Do deep squats, even performed correctly, increase a chance of issues with meniscus after surgery, after 2 surgeries, specifically meniscectomy and repair? They're wondering if they should stop squatting below 90 degrees.
Again, a little bit difficult to know for sure, just because we don't have the specific scope pictures or MRIs, but doing a deep squat beyond 90 degrees certainly puts some stress on various aspects of the meniscus. So for example, when we do meniscus repairs, what we typically do is we immobilize the knee in full extension, meaning that the knee is fully straight. And we limit range of motion from 0 to 90 degrees for the first 4 to 6 weeks at a minimum, because we know that as the knee bends deeper into a deeper squat, that does put stress on the meniscus repair, which we try to avoid, once we put stitches in. So deep squats certainly does put stress on the meniscus. So it's all dependent on, how far out that patient is from surgery. Certainly if it's causing pain or discomfort, it's probably not a good idea. And there's probably not that much more benefit to doing a deeper squat than just keeping your legs at 90 degrees. So I always tell my patients, if you've had any knee problems in the past, or if you're still struggling with knee problems, that keeping your lunges, your leg presses, all of your squats to 90 degrees or less in terms of a knee bend is probably beneficial. It's safer for the knee. You're still working the muscles. You're still getting a good workout. You're still strengthening, all of the muscles surrounding your knee that act as dynamic stabilizers. So it's one of those things, again, where it certainly wouldn't hurt to keep it at 90 degrees or less, especially if you've had a history of previous meniscus surgeries, especially a repair.
Okay. How often could you get a cortisone shot for a conservative treatment?
For the knee, we will typically do cortisone every 3 months as needed. So while you can get them every 3 months for individuals that are, on that 3 month, year over year, that may be a time. Sometimes we'll look at other options. It depends on each person and what they're getting them for, but every 3 months is kind of the standard of the knee. But I would tell people to go as far as they can beyond that if they're able to.
Can you touch on whether or not PRP or stem cell injections would be beneficial for a meniscal injury as a non-operative option?
Sure. So PRP and stem cell treatments or bone marrow aspirate treatments, those are all still relatively new therapies, and there's still a lot of studies being done to determine, what effects those have on the knee structures like the cartilage and like the meniscus. As far as non-operative treatment for a meniscus tear, injecting PRP or stem cells will not get that tear to heal back together. The only way to get meniscus tissue to heal back together is to mechanically put it back together with stitches. And then oftentimes we can inject PRP or stem cells or bone marrow aspirate into the knee in addition to increase some healing factors. But simply injecting PRP or stem cells into the knee will not heal whatever tear that you have in the meniscus. That being said, there are a lot of pretty good studies out there that show PRP is a very good treatment for early mild to moderate arthritis in terms of stabilizing the cartilage that you do have. And many patients do experience benefit from PRP injections when treating, mild to moderate arthritic changes that may or may not be associated with a meniscus tear. For example, like if you have a degenerative tear in your meniscus and some early arthritis, then it may actually be reasonable to trial like PRP or stem cell injections as a very reasonable therapy to help out with the pain that you're experiencing.
Okay. Yeah, we do have non-operative physicians that perform PRP injections, so that is something that is available as a service at OSMS. All right. Looks like we have time for one last question, so this is the one that we will end on. Any idea what would cause occasional sharp pain behind the kneecap when ascending stairs? This person says that their knee also sounds like a dry door hinge. Possible cause was a sudden stop in motion of their foot. Biking is okay, but not the elliptical machine.
Yeah, so this it sounds like what we call just kind of for layman's terms, a kneecap problem, not typically affiliated with the meniscus. Those problems that are in the front of the knee, certainly the meniscus can cause swelling of the knee, which can make pain in different spots. But for this person, the things that she or he is describing sounds like kneecap arthritis. When you have grinding behind the knee, or in her her his description, sounding like a dry door hinge or a rusty door hinge. Going upstairs is when you load the kneecap and you're putting 4 to 8 times the body weight through the kneecap. So all those signs lead to, or at least give number one differential to be a kneecap arthritis problem.
Well, thank you both, Dr. Parman and Dr. Ziegler, for your insight tonight. Like we've mentioned a few times, please feel free to give us a call. Our number is 920-430-8113. Otherwise, you can go to our website at osmsgb.com and you can self-schedule an appointment there. Our doctors would love to help you out, evaluate you, and figure out how to get you back to doing the things that you love doing. So thank you all for joining. We hope you found this helpful and have a great rest of your night.